I'm an endocrinologist, so I'm apologetic that I'm in the hall with a lot of cardiologists, but my topic is quite pertinent because we do supply the cardiologists with a lot of the future business that they will see, i.e. coronary vascular disease. First thing I want to say, because we have a lot of general practitioner colleagues in the room, is that I heard a lot about immunogen. This is not part of my talk, but can I just use this forum to say that if somebody is on immunogen, the endocrinologist in me cannot get away by saying this, which is, if they're on immunogen, please make sure that if, your patients have thyroid function tests every 3 months without fail. Immunogen-induced thyroid disease occurs in 5 to 15% of people on immunogen, and the half-life of immunogen, which is quoted, which is 100 days, is actually untrue. So immunogen and the iodine within it can last for up to a year and a half, and immunogen-induced thyroiditis can occur 1.5 years after immunogen is discontinued. So important to pay attention.
We'll never use it again.
So my topic is 3G. Most of you will say, oh God, it's now the 4G era, but I promise you in the next few slides it'll make sense. And I won't unfortunately have a song and a dance, but from my hairstyle you can tell that I'm quite progressive and I'm a mover and a shaker. So most of you would have met Bob. So 60-year-old, middle-aged, well, middle to nearing retirement age, truck driver, has diabetes, all the risk factors for coronary vascular disease, and therefore also had an acute coronary syndrome several years ago, for which he had PCI, i.e. an eluting stent to the LAD, and has residual disease which does not need to be treated. So his HbA1c is not terrible. So you'll see this a lot, not terrible but not perfect, doesn't meet the guidelines for the management that he should achieve. All the usual medications at your disposal in New Zealand, and all the secondary prevention medications that you would start. Now, he doesn't want to start insulin like many people. Now, what can you do for him? This is an important topic, and we will be challenged with this for many years to come. So 3G essentially is the way forward. So the first G is the GLP-1 receptor agonist, so glucagon-like peptide receptor agonists, and gliptins, which are the dipeptidyl peptidase 4 inhibitors, and the newest kids on the block, which is the most exciting, which I really, really love, but unfortunately the disclaimer is that we can't get it in New Zealand funded in the moment, is the gliflozins, which are the sodium glucose cotransporter 2 inhibitors. So the important thing is that the FDA now requires that all new diabetes medications, including insulins, have a cardiovascular outcome trial to prove that they are safe or superior to standard care. So the important thing is also that each of these new non-insulin agents, they only improve your HbA1c by about half to 1%, which is the old way of reporting HbA1c, but now it'll be equivalent to 5 to 10 millimoles per mole in our new way of reporting HbA1c. So it doesn't really replace insulin. So if you've got people with very poor control up front, HbA1c, which is 85 to 100, or the serum glucose when you see them in a random blood test or a capillary blood test is about 15 to 20, then you'd want to start or talk about insulin. So just as a preamble, cardiovascular disease is very important to type 2 diabetes. It will affect almost all your patients that have diabetes, regardless of whether or not they have good control. So 60% of them or more will have cardiovascular disease. And even if control is good, i.e. meeting the criteria, i.e. 50, 55 millimoles per mole over several years, their risk is still at least twice somebody who does not have diabetes. You shouldn't tell your patients that, of course, but this is the fact. Up to 70 to 80% of people with type 2 diabetes will die of cardiovascular disease, and at least half of that mortality is from coronary artery disease. So another slide to say that it's not great for people with diabetes, and large trials, including up to about 500,000 people, prospective trials show that they've got increased risk of coronary artery disease and non-hemorrhagic strokes. So the incretins. So that's GLP-1, as I mentioned, and also its cousin, GIP. GIP really is not a target for pharmaceutical development because there's increased resistance of GIP in the body of somebody who's got type 2 diabetes. So all the pharmaceuticals we have are all targeted to GLP-1. So GLP-1 is secreted by cells in the gut. So GLP-1 is in ileum and colon, and GIP is in the duodenum and jejunum. There's some overlap. So the incretin effect is important. We've known this for about 2 decades now. So that's essentially the augmentation of oral glucose-stimulated insulin secretion by beta cells, which is augmented by incretins, which are those gut hormones we talked about. So in type 2 diabetes, you've got both a decreased secretion of GLP-1 and also a decreased response towards it. And as I mentioned, there's a resistance to GIP, which is why we don't use it as a pharmaceutical target. So that's a little slide to say, to show you what an incretin effect is. So the top solid red dots would be, and left and right will be control subject and then the type 2 diabetes patient. So the solid one would be an oral glucose load, and the one at the bottom, which is the emptied out dots, would be a response to an IV glucose load. So most insulin would be secreted maximally by 60 minutes. So you see that peak there, that is the incretin effect, that big gray arrow. And in somebody with type 2 diabetes, that is much diminished, and that is the reason why it is a target for therapy. These are all the other magical good effects of GLP-1 that we see in both animal studies and human studies. Of pertinence for human studies, it will be the decreased desire to have food, so it affects the hypothalamus, decreased gastric emptying, and decreased acid secretion, and all other magical things that we have studied in animals. In fact, in terms of infarct size in rodents, it manages to reduce infarct size as well. So the first GLP-1 is exenatide. It was developed from the saliva of the Gila monster, so exendin 4. But since then, we use recombinant technology to make things which look like your own GLP-1, but are not based on the saliva of Gila monster anymore. So most of them are all manufactured to be resistant to the natural enzyme which breaks it down, which is DPP4. And because of that, all of them are proteinaceous and require subcutaneous injections. But one is currently in development called semaglutide, which can be an oral pill when it's approved. The second line would be all the GLP-1 agonists which you have in the market. So if you pay attention, everything that ends with a TID, a TIDE, will be a GLP-1 receptor agonist. Some are once a day, some are once a week. The disclaimer is that we don't have this funded in New Zealand, and the cost is up to about $300 per month for the patient that wishes to go on it. We do have exenatide LAR, which is the long-acting version, and liraglutide. Liraglutide is currently also approved for weight loss internationally, and you can lose up to 10 to 15 kilograms on liraglutide alone. So the weight loss is about 5 to 8 kilograms over about a year. It's probably the most potent non-insulin agent to reduce HbA1c, up to about 10 millimoles per mole. And it's safe up to people with CKD3B, i.e. eGFR around 35 to 40. So side effects that are most common for GLP-1 receptor agonists are the GI side effects. This is the most common reason why people would discontinue. There are local side reactions. All the rest of them I wouldn't worry about because they're extremely, extremely rare. So the important thing is the good effects that some of them have on cardiovascular outcomes. So the important trials I've just listed there, I'm very sorry that they are busy. Most of the trials are comparable in terms of their patient population. And the only thing to take out of this is that the two that are important are liraglutide and semaglutide. So they show significant relative risk reduction in terms of cardiovascular death for liraglutide in the LEADER trial. And also, in terms of semaglutide, there was a significant reduction of the primary outcome, which is a 3-point MACE. So a MACE is essentially non-fatal MI, non-fatal stroke, and also cardiovascular death. So sometimes trials would report 4-point MACE. The fourth point would be hospitalization for unstable angina. The other two trials, unfortunately, lixisenatide and exenatide, didn't show any benefit. So we are uncertain whether this is a class effect. So gliptins, the DPP4 inhibitors. So these are the gliptins that are available in the world. Korea, Japan, Russia, they have a separate approval mechanism compared to FDA, and they have some of their own gliptins which are not available elsewhere in the world. So again, in New Zealand currently they're unfunded. The ones available are sitagliptin, sexagliptin, vildagliptin, and they're about $90 to $120 per month, available through pharmacies. If you write them a prescription, it's negotiation with the pharmacy between patient and pharmacy as to how much they'll pay. The mechanism essentially is to inhibit the breakdown of GLP-1 and therefore prolong the activity of GLP-1 endogenously. So it's safe after CKD4 for most of these agents. Most of them will require dose adjustment except linagliptin if you do have renal impairment. And it's weight neutral, doesn't cause hypoglycemia unless you use it with medications that are known to cause hypoglycemia, i.e. insulin and also sulfonylureas. Side effects are relatively rare. GI side effects of sitagliptin, and the rest, i.e. symptoms of upper respiratory tract infection, which are quite rare. The other things I've listed there are just things that we've seen in trials, but they are quite rare, or the relationship with pancreatic carcinoma and pancreatitis is unproven and also quite rare. So in terms of the cardiovascular outcome trials, there are 3 so far, and most of them, essentially, the take-home message is negative. So not better than standard therapy, not better than placebo, but the important thing to take out of this is that there was a signal of concern in terms of increasing the risk of heart failure, especially for sexagliptin and non-significantly in alogliptin. So if you had to use these medications, people who are at high risk of heart failure, I had in fact had an echo that shows an ejection fraction that's low normal, then I wouldn't recommend using it in these populations. And then I come to the most exciting one, which is the gliflozins, so the SGLT2 inhibitors. So this is just a diagram of how it would work. The SGLT2 is actually a channel in your kidneys, proximal tubule, which essentially allows you to absorb glucose. So by blocking it, the simplistic mechanism is that you would pee out glucose and lose calories without doing anything. The SGLT1 channel is actually in the latter part of the proximal tubule, also present in the gastrointestinal tract, and it's not really a target of therapy, but currently we have combined inhibitors currently in trials for type 1 diabetes. So the ones available in New Zealand at the moment are dapagliflozin and empagliflozin, again unfunded, $100 and $120 per month. Elsewhere in the world, all 4 are available, and in terms of cardiovascular outcome trials, ertugliflozin is currently going to be going under a cardiovascular outcome trial called VERTUS, and dapagliflozin, we're awaiting the cardiovascular outcome trial results end of this year, and that's about 17,000 people in that trial. So huge trials. So the good thing about gliflozins is that they promote weight loss over about a year or so, up to about 4 to 5 kilograms. It does reduce your HbA1c by about 5 to 10 millimoles per mole, roughly about 5. And it also helps by reducing your blood pressure without a compensatory increase in heart rate, which can only be a good thing. The important thing about gliflozins is that they can't be used in people with advanced kidney disease. So in terms of canagliflozin and ertugliflozin, not in people with eGFR less than 30. For empagliflozin, not in people with eGFR less than 45. And for dapagliflozin, not in people with eGFR between 30 to less than 60. So all the side effects I've written there are, again, extremely rare. There's a lot of concern in literature about UTIs, but in the next slide I'll show you that actually they were very, very rare in the trials that we've shown. In terms of canagliflozin, some of you might have heard that there was concern in terms of, compared to placebo, that there was increased risk of amputations, but I'll show you again why this is actually pretty rare. So this is the important slide. So now we have a medication for diabetes to improve HbA1c, improve blood pressure, which also has excellent cardiovascular outcome trial data. So in terms of the most important one, there'll be the EMPA-REG trial, which was published in 2015, and huge cohort of patients. All of them had established cardiovascular disease, as opposed to CANVAS and CANVAS-R, where only about 66% of them had established cardiovascular disease, and the rest were people with high risk. So there was a 14% relative risk reduction in terms of the primary outcome, the 3-point MACE, and that's similar in canagliflozin. And the second thing, this is the first time we have an agent that reduces the risk of hospitalization for heart failure. Both empagliflozin and canagliflozin have equivalent effects. But the important thing about empagliflozin is that the additional effects on cardiovascular death and all-cause mortality was seen. There was a trend towards significance in the CANVAS and CANVAS-R trials, but not significant enough. The second table will show you the side effects. They're all very rare. We didn't see much more UTI compared to placebo. In terms of amputations for canagliflozin, all the people that had amputations had very high risk of amputations already, i.e. they had known peripheral vascular disease or had already had amputations, and all of them was preceded by a known risk factor for infections, i.e. foot ulcers. So with that, this is a little table as to why we think that the SGLT2 inhibitors have all the effects on cardiovascular mortality and also on cardiovascular outcomes. None of this are proven, of course, but this is the current thought process. So with that, if I went back to Bob, in the future when these agents are available, and I must say that empagliflozin and dapagliflozin have already been submitted to Pharmac, and they've already been approved for use since 2015. It's just that they haven't managed to negotiate a good price with the manufacturers, i.e. that's why they can't be funded. But we already have the evidence, and it's already in the pipeline. So back to Bob, if you were going to use an agent for him, which one would you choose? For me, it's going to be empagliflozin, because he already has an infarct, he's had high risk of heart failure, and the one that's going to make the biggest difference to him would be empagliflozin. With that, thank you.
Well, now, I'm sure you're all full of questions. Let's go. Will there be a tendency, do you think, for people to just take these medications so they can lose weight?
Yes, but that's not necessarily a bad thing. So, but it is not indicated for weight loss. It's just one of the things that would be beneficial on top of everything else.
Yeah.
But if a person comes to you and they don't meet the criteria, they're not diabetic, then I wouldn't start this for weight loss. Liraglutide is indicated for weight loss when it comes, so we can prescribe that instead.
And so how do you personally regard this? I mean, you look a man of enthusiasm, and I noticed you're moving very well as you were talking. So is this a big window of opportunity? Is that how it is for us? I mean,
Yep, so I think this is the first time in diabetes. I mean, if we look at the old trials, the DCCT trials and the UK-PDS, metformin had a signal of benefit for people who are obese in terms of cardiovascular outcomes, but this one was a direct trial designed to look at it, and we have an agent that shows that it's working. So it would be, if we could get it into this country, funded. So generally speaking, and just this is an aside, so the ADA and the European Association for the Study of Diabetes, as of this year, they've just presented it in their joint conference. The guidelines coming out for management of diabetes now will no longer be like the olden days. Metformin, yes, first, but we're trying to phase out the sulfonylureas, and these agents will come in as second line, additionally. And now we're selecting these agents based on the patient, rather than just, yep, metformin, we don't have anything else, sulfonylureas, i.e. we select it based on their particular features, i.e. a person who's had coronary vascular disease, heart failure, or high risk of coronary vascular disease, and we select these agents based on that, rather than, yes, the glycemic control is poor, let's add sulfonylurea and only add these because there's nothing else. So that will change the face once we can get these in. So we will be using a lot of this once it comes into the country.
well, I'd like to thank you very much for a very enthusiastic presentation. Everybody.